All right, welcome everyone out to our May Utah Children's Care Coordination Network meeting. We're excited to have you here today. And we'll just go ahead and jump in. I know people will still be joining us, but we want to make sure we have enough time for our presenter today. So our agenda today will get started as always with some announcements and updates. We'll have our case share and brainstorming. And then our learning session today is all around child life and adaptive care. And that will take the bulk of the meeting, and then we'll wrap up with any questions at the end. If you haven't already, please take a moment to update your or rename your profiles. On your picture, you should see 3 little dots in the upper right-hand corner. You can go ahead and select rename, and if you can put add your agency and your role as well. That kind of helps us visually get to know each other as we're in this meeting. And we may actually do a round of introductions today as well. I just wanted to preface everybody with that. We will likely do that after our brainstorming session if we have time between brainstorming and our learning sessions, just because we haven't done introductions in a long time, and we have a lot of new people joining our call lately. So we want to give everybody a chance to kind of get to know each other. But if you'll start by renaming your profile, and then as always, if you can join us by video, we love to see your faces, and that helps us to also get to know each other. So for announcements, the Spark study is still ongoing. We always encourage everyone to enroll in it if they are able to, enroll families in it, especially those with new diagnoses. And you can see there's a lot of information here. This will also go out in the resources of the month, so you don't need to worry too much about scrambling to write things down. It will be there as well. Some other announcements, the Primary Children's and the Health Department, as part of the Transition Summit, are holding a film festival contest for youth. This is for youth that are ages 12 to 22 to enroll in, and they're looking for youth to submit videos about their transition experience. So there is some prize money available. So if you know any youth that might be interested in this opportunity, we encourage you to share this with them. And let's see, did I see, Julie, did you have anything else you wanted to say about this? Julie Southwick is the one that passed this on to me.
Looking for kids to submit films. We're trying to work on some marketing so that we have more kids of it, aware of what's going on. And Stephanie Sund and I are actually going to work with some of the kids and see if they have better ideas to draw in some applicants. So you can just get the word out. That would be great. We do have prizes as well. We're going to have some monetary prizes.
Great.
And Athena, this is Eric. I was just going to say too, part of the goal with this is, besides getting youth voice on sharing their transition experience, we would like to be able to create a repository, if you will, of all of those youth experiences, so that providers and other people who are working with youth who are trying to transition to adult healthcare providers can share these video experiences with their youth. So there's kind of a peer-to-peer opportunity to share that a lot of these transition experiences are doable. Things like filling your prescription, or what it was like when I went to college and had to go to an adult healthcare provider, meeting with my provider on my own without my parents being there, things like that, that we think other youth who are going through that transition experience could relate to. And it's not the same as having, adults who don't get you, trying to force you into doing these types of tasks. So it's kind of a dual purpose. Let these youth share their voice, but also share their voice with other peers in a way that empowers youth to know that they can do these, what appear to be challenging things, they can do these themselves. and learn how to experience that adult world, particularly in the adult healthcare setting.
Great. Does anyone have any questions for Julie or Eric about this film festival contest? It looks like there's some time on it too. Submissions aren't due till the end of August, so. All right, our next announcement is that we have the Utah Parent Center is also holding their annual Family Festival coming up here in just a little over a month at the end of June. That will be at Mill Creek Commons, and again, this is open to families of children and youth with special healthcare needs. Does anyone from Parent Center want to hop on and say anything about this? I think Abby is the one that submitted it to me, but I don't see her on the call today.
No, I'm actually here today. It's
Oh,
Colleen.
you are. Hi.
We're really excited about this. We have lots of room for resource fair vendors still. We haven't put out that actually to super general public because we want to make sure that our agency providers and our network friends get the opportunity to get in first and stuff. So let us know. But the Mill Creek Common area is so fun and so new. They have a roller skating little rink. We will have limited numbers of free rentals available. The thing I'm most excited about is this talent show again. If you attended last year, we had it at Wheeler Farm and the talent show was in the barn, and so many people had to miss those incredible talents from, again, self-advocates. This will be for our youth with disabilities and individuals with disabilities to showcase their talents. But the Mill Creek Common has this nice big stage right in the middle of the area. So everyone can be able to see this. This will be a super, center point of the event. It's going to be really cool. And then at the end, a lot of the DDC, the council members, and again, those self-advocates have been planning a dance party for after. So they have a great playlist they're making. We're really excited for them to share that as well. So this is going to be a really great opportunity for families. I think it'll be fun. Let us know if any questions.
And you said that you are still looking for vendors and
Yeah.
people to join in the resource part of it.
Yeah. Yep.
Great. And should they reach out to you directly?
They can, or I will put the link for the festival in the chat as well. That should have actually a Google form you can register for right online. So, but yeah, you can reach out to me as well.
Okay, and I see Colin posted in the chat if you can verify whether or not
Yes.
up is secured.
I will check with Julie Ray and confirm that for you, Colin. Sorry about that.
Great. Any other questions about the Family Festival? This is good. It's fun to see all the events that are coming up over the summer. Gets me excited for it. All right, so for medical home portal updates, we had a couple content updates this past month. One on the acidemias, PKU, and then also the obesity in children and teens pages were all updated since our last meeting. And then some content that's relevant to today's learning session, I just wanted to highlight. We do have a page on adaptive play and assistive technology, and it talks a little bit in there about how child life plays a role in that, especially in inpatient hospital settings. We do have a page all on child life services, and this is written more for a family audience. So if you have families that are going to be hospitalized and you think they might benefit from knowing a little bit more about child life services, this page is a really great one to share. Again, it can be translated into multiple languages as well. I'll just go ahead and show that on the portal. So if you search the term child life at the top, it's going to show some of these results I'm talking about. So this child life services, you can see it's in the section for families. So this would be a really appropriate resource to share questions and answers is like, what is it and how can I get in touch with them, and some other resources. And this page Here's the Google Translate tool. So again, it could be really useful to a family that's maybe not as familiar with how Child Life Services works and is English is their second language. This would be a great way to kind of explain what those services are. And the other page that I wanted to highlight is one called I Can Play. And this one was written by one of our Utah, it's specific about a Utah program at Primary Children's. And so if you want to know a little bit more about it, here's a great page all about it as well that you can read up on. All right, today for our case share, we have Taylor Harris from Utah Valley Pediatrics. So I'm going to go ahead and turn the time over to her for our case share today.
Awesome. Thank you so much. So yes, my name is Taylor Harris. I'm with Utah Valley Pediatrics and I'm fairly new to the care coordinator role. So I am excited to share this case with you. I have some resources prepared that I was able to provide with the family. If anyone has any input, I would love to have any extra help that I could give them. So the case that I have prepared today involves an infant who was diagnosed with Down syndrome, and this was not known or diagnosed prenatally. The infant had a very complicated delivery. The birth mother had no prenatal care. There was no diagnosis of Down syndrome. She went into labor, had a difficult labor that required a C-section. Mother refused a C-section and delayed delivery. The infant's heart rate could not be detective, and they had to do a stat C-section due to the heart rate. The infant was apneic at birth with no detectable heart rate. Infant required positive pressure ventilation. Chest compressions were started, and the patient was intubated. And once the patient was stable, she was then placed with her adoptive family. Upon exam after birth, the patient was evaluated and screened for hypoxic ischemic encephalopathy. She did meet criteria for therapeutic hypothermia, and it was initiated. During this hypothermic period, she suffered seizures, was started on phenobarbital, and that they were able to stop after 8 days. The MRI showed findings consistent with severe HIE. The MRI also showed concerns for cortical visual impairment, and the family was told to follow up with neurology in 3 months after discharge. That would put that into the July timeframe. The newborn screening was done in the hospital, found congenital hypothyroidism as well. She was started on Synthroid and told to follow up with endocrinology in 1 month. While she was hospitalized, the patient had multiple echocardiograms throughout the hospitalization. The echo showed fenestrated atrial septum with at least 3 defects and a small amount of left to right shunting. They said that no outpatient follow-up was needed after that they were established, but just to kind of watch on the PCP level. Patient was discharged on oxygen due to a history of respiratory failure and persistent pulmonary hypertension, and she was discharged on home oxygen. The swallow study showed aspiration, and the patient required an NG tube for feedings. They were discharged with the NG tube and told to have an urgent follow-up with the HEFT clinic upon discharge. And then at this point, the patient came into our clinic for their 2-month well child check, and this was about 12 days post-discharge. At this appointment, the parents came in saying that they had referrals with 7 different providers. When they left the hospital, Primary Children's had coordinated the HEFT clinic and the appointment in our office, but they still had 5 other referrals that they hadn't heard about. The parents, they did go to the HEFT clinic. It was scheduled about the same time as their well child check. And as they were on their way to the appointment, the HEFT clinic canceled the appointment and rescheduled for 3 weeks away. So now I'll go into the resource section here. So the patient, they were in for their 2-month well check. They didn't know where to begin to start to coordinate all these appointments, what kind of took precedent, what they needed to really focus on. These sweet parents just had a very complex, delicate baby, and they felt very overwhelmed with what lay ahead. So I got on with the coordinated schedulers at Primary Children's to get these appointments going. Our office is located in Spanish Fork, so I wanted to try to get as many appointments as possible in Lehigh at the new Primary Children's, so that they wouldn't need to take baby and all of her equipment up to Salt Lake. And And we decided that the 3 most important critical appointments were going to be neurology, endocrinology, and the HEFT clinic. So we started with neurology, that required a 3-month follow-up. When I called scheduling, they didn't have any openings until September, and they weren't going to accept new appointments even to be scheduled until then. I tried to help the scheduler see that Primary Children's was the one that told us to follow up with them and that it was a very complex case. They referred me to try the Razor scheduling tool to try to get an appointment. But as we were speaking, she said that somebody had called on another end and canceled an appointment the following Monday. We realized that it was a little bit premature for the appointment, but it was the only appointment available till September, so we had to take it. Endocrinology wanted to see the patient back 1 month after discharge, but scheduling couldn't see the patient until June, and that would be 2 months post-discharge. While that wasn't very long to wait in the grand scheme of everything, it just felt very far away for the parents for a medically complex child. In the meantime, I wanted to do what I could to help these appointments run smoothly. So when the parents were in, I sat down with them and helped them understand what a care plan was. I reviewed the discharge summary with them, went over the hospital documentation to have an up-to-date document for the parents so that when they do visit with a specialist, or if they had to go to the emergency department, that they would have a document with an up-to-date history for the patient. The coordinated schedulers, they were a very helpful resource. It was so nice to be able to call one number to schedule all of these appointments. However, we were both, us and them, we were both hoping that there could have been better appointment options for this patient. Something that I wish could have been a little bit different was that the parents would have been educated a little bit better to know that if no one reaches out after they were discharged for these appointments, that they can reach out to somebody else, or that I was here for them, or that they could follow up with scheduling themselves. Sometimes these procedures are not 100% foolproof, and these situations just fall through the cracks, unfortunately. But by the time the patient got to us, we were already 2 weeks into the follow-up period for a 1-month follow-up, and we felt a little bit behind the ball already. I also helped the family apply for the medically complex children's waiver, get that process started. I know that there can be a wait list, so we wanted to get that going as soon as possible. Some of the other care coordinators at Utah Valley Pediatrics had made a care coordinator pamphlet. So I had updated that. This pamphlet had information about what a medical home is, how I can be helpful to the family, how a medical home can help benefit the parents and children. It had my contact information and helpful websites like the Medical Home Portal, Utah Parent Center, Family Voices, for them to reference themselves. And we made sure to set up early intervention services such as speech, occupational therapy, and physical therapy so that they could have these resources in their community. But overall, this case just taught me that I need to be watching my provider schedules to try to catch these medically complex children when they come in early so that we can coordinate earlier, because even a few days could have helped everything. I'm grateful that that appointment had canceled so that we were able to get them in with neurology, and overall it just taught me how to be a little bit better of an advocate. So that is all I have prepared.
Thank you, Taylor. That's a great example, I think, and a very common issue of parents feeling overwhelmed and not really knowing where to start, especially with a new diagnosis. So I heard you mention the coordinated schedulers at Primary Children's, the medically complex children's waiver, Utah Parent Center, Utah Family Voices, Medical Home Portal, and early intervention. Does anybody else have any other resources they think or had thought of while Taylor was describing this case that they think would have been beneficial for this, or is a good place for this family to go as well?
Athena and
Yeah.
Taylor, this is Heather from the Integrated Services Program. Just a couple of things. Like, first of all, like, what a beautiful job that you've done for this family. All the resources, all the education that you've done in such a short period of time sounds incredible. I just wanted to mention a couple of things. When we work as care coordinators with families with medically complex children, one of the things I really like to do is help them with a care notebook. And you can look on the Medical Home Portal on how to help them put this information together. You can, get a 3-ring binder for them, or you can just kind of help guide them, through the process they're going to be dealing with so many different appointments and professionals and possibly, medications and resources and connections. And when you put a care notebook together, they can take these care notebooks to these various appointments, and it really helps them feel kind of sane and organized, to kind of see like, okay, this is what happened last with neurology. Here's our neurology update, and then they can show that to the next provider. And I know that it's nice to we have a lot of things on the computers and, can share that way, but as they get in with early intervention and more community resources, it can be just a lifesaver. And the families that we've done this with are so appreciative. So it's just an idea. The only other thing that I wanted to mention is there's a resource called Gigi's Playhouse in Layton. They work with families that have Down syndrome. So even if they're far away, it still would be a nice resource for them to have, just because they really are just wonderful in the community for families that have Down syndrome. So they may be able to network with other families there. They also have an early learner program for 0 to 4 or 0 to 36 months. And they can, like do song and like music therapy, and the parents can go to that as well. So it just might be a nice resource for them. Maybe not now, but maybe in the future. So that's all I had.
I had a couple that I thought of again that when we try to, I don't know if they've already been referred to even just the Utah Down Syndrome Foundation. Has some really cute things for families, but also again, being that this was not something that was anticipated and now you have an adoptive family included, they might even still like some of the peer information and materials they have available. Like this is a kit that you would take to a child's classroom or something. But again, it's just very basic information, very elementary education. The other thing that they provide, and I think that because this child is still so teeny that they would be accepted into it, is they provide a new parent, like they call it a little like shower, you know what I mean? So they have these newborn and expected mother support groups. And again, you get a little fun kit, a care package for new and expected parents. They can even probably still be invited to the new parent breakfast that they do. They do a quarterly new parent breakfast, and I think it's for families that have kids up to 3 years old, actually, to network with other families. But they also do, again, some educational pieces and stuff. So I think that that might be something that you could refer them to. But again, the other first thing I thought of was that care notebook. Again, I got so reliant on, my chart and just being able to pull notes up on my cell phone and stuff. But really with some of the things even we're still going through with my daughter, we've had to go back to that handwritten visual thing that's taped to the fridge for everyone to use. You know what I mean? The scheduling pages. Again, that communication log page has saved my life these last few months as we've been going through some med changes with my daughter. It just so many things that instead of having to scroll back through appointments or go in and out of appointments in my chart to remember things that I, talk to my doctors about, to have that visual, even if it is like handwritten right there in a notebook or in that 3-ring binder, it feels so old school, like that's what we did 20 years ago. That it actually has helped me so much more to revisit that tool. So that's, yeah, for sure the care notebook.
And I was just gonna add on, Colleen said most of them, but the Utah Birth Defects Network worked with the Down Syndrome Foundation and to create the New and Expectant Parent Resource Guide. And I put a link in there, but we have hard copies. If Taylor, you would like us to send you one. If you don't have any, we could send some to your clinic, but happy to do that if that would be useful.
You know what, my other thing that we have a whole presentation, our whole new diagnosis, now what, workshop is based off of the medical home portal information on, like, I think it's like the 10 best things you can do after you get a diagnosis or something. I can pull up the exact page, but it also might be something, because again, it starts with take a breath, find your village, find a community, kind of goes into those steps and finding good, reliable online information, great communication steps and tips for working with professionals and providers. Even just again, knowing how to say, I don't understand what you just said, or that does not make sense to me, or this is language that I'm not familiar with, things like that. So that was the other one that we have some materials and information available on, those next steps after a new diagnosis. But it's a little bit more emotional, stuff. So
Great. Well, we'll be sure and get all those resources linked and sent out in the resources of the month too. I think these are great resources for a lot of families with new diagnoses, not just those who are maybe working with a new diagnosis of Down syndrome. So great resource sharing, everybody. We're so appreciative of everyone's input in this group. We do have a little bit of time for brainstorming and case sharing. If anyone else has another case, another case that they want to share, or any news or announcements, new resources you found that you just want to highlight in this meeting for the group. Yes, go ahead, Carrie.
Yeah, this week maybe you guys know about this, but the Bountiful Doulas, I was able to reach out and have a conversation with them. They do daytime support and overnight support, and I can share like the information with you, Athena, after, and you can send it out in the notes. But they can go into the home and work with a new mom, with like things like feeding assistance, learning how to prep nutritious meals, even if mom needs a nap. Right now, they are currently not billing insurance, so it is all out of pocket cost. It's $40 an hour for daytime help and $45 a night for nighttime help. So it is out of pocket, but they are able to take like FSA and HSA cards. However, they are working to get some insurances, and the one that they're focusing on the first is Medicaid. So I'll share that information with you, Athena, and then you guys will all have it at your fingertips to use. But I was kind of excited to find it because I'm working with a particular family that has triplets and twins under the age of 2. Mom really wants to just be able to take a shower at least once a week. So I'm pretty excited that we're going to be able to provide this for them. But if there are triplets or twins, the cost does go up, just FYI. So.
Great, thank you for sharing that, Carrie. Anyone else have anything they want to share? All right, well, we'll get started with the learning session portion of our meeting then. And today our topic is on child life and adaptive care. We're excited to welcome Emmy from Primary Children's Hospital with us today. She is a child life specialist there, and I will go ahead and turn the time over to her for our learning session.
Hello. Hi. Can y'all hear me okay? That's right on. I'm not as familiar with Zoom. Intermountain uses Teams. So pardon me if I fumble. It's nice to be here with you all. I recognize more of your names than I thought that I would. Colleen has to listen to me talk about adaptive care for the 70 billionth time. Colleen, what do you think? Maybe.
I love it. I love this though. So it's perfect. You're great.
Yeah.
I'm excited.
I love it. Yes. I'm curious before I get started too much, who of you knows what child life is? In general, adaptive care, I wouldn't expect as many of you to know about, and we'll talk about both of those things. But child life, anyone had an experience with child life or child life specialists at a hospital, either personally or with anyone that you've worked with? It would be helpful to know where you're coming from. I'd love to hear you share. Sorry, my mute button is covered.
This is Eric with the HHS, and I know about the concept, but I don't really know all the particulars, and I understand it, kind of from that hospital perspective of, kind of integrating. I'm going to stop right there because I make a fool of myself. So I'm just going to shut up. I'm going to say I know about that child life specialist, and I hear about that quite often, with meetings that I go to with primary children's and some of that. So I'll just leave it at that and know that I'll be far better informed by the end of this session.
I love it. Glad you've heard of it at least. That's better than a lot of people. How about anybody else? Anyone had an experience?
Yes, when I worked up at, and this is Heather again from the Integrated Services Program. So I am a nurse, and when I worked up at Primary Children's Medical Center, the child life specialists were my best friend. They were so amazing. They helped just put the families at ease, and the kids at ease, and help them with those procedural things. Like, a child's getting an IV and they're there to kind of help comfort them and distract them, and as best as possible, make things fun in difficult situations.
That's great. Thank you for sharing. Anybody else? You can maybe hear one more person if you've had an experience.
Yeah, I also worked at primary children's at one point for several years. And I loved when child life came in, and especially when a kiddo was gonna get an IV, would use a good like adult to mimic whatever was gonna be happening to the child and have to help them understand what was going to happen. I thought that was a lovely thing they did for the kiddo and for the family.
That's great. It just helps to kind of know where you all are coming from. It sounds like some of you have just heard of child life. Some have had an experience as a worker. So I'm glad to know you got like a little bit of a background. It's getting different these days, but when I started in child life, it was just assumed that no one knew who we were or what we did. So that's always heartening. Okay, let's see. Have I successfully shared my screen? I believe that I probably have. Will someone tell me? Oh, there's your faces. Have I successfully shared my screen? Will someone give it? Love it. Okay, sorry, couldn't see your faces there for a second. So my name is Emmy. I am a child life specialist, obviously. I have worked as a child life specialist for 8 years, all of them for Intermountain. I have a predominant amount of my experience is in the emergency department. I worked in ERs kind of just across the valley, Utah Valley Hospital, McKay-Dee, a little bit at primaries. And then the last 2 years ago, I took a new position in child life, still working under my credentials, but starting the adaptive care program. So that's my background. I now work just up at primaries and coordinate the adaptive care program. So we will kind of jump in here. We'll talk about what is child life, the benefits for kids, and like why it's important. We'll talk about the services that we provide, and then we'll jump into the adaptive care program because we think both of those resources would be helpful for your teams to be aware of to refer families where appropriate. So to dig into child life, my elevator pitch for child life is our goal is to reduce the negative impacts and traumatic effects that hospitalization and medical events can have on kids. That's kind of the general mission of child life. We do that in a myriad of ways. That can be through assessment, quality interventions, prevention, advocacy, education. We're providing developmentally appropriate knowledge about what's going on. We're making sure that kids have access to critical play experiences while they're hospitalized or experiencing differences in their body. We love this line. We embrace the value of play as a healing modality. We don't ever mind being called the play ladies here at the hospital. That lady with the toys, where's the person with all the bubbles? That to us is the highest compliment because almost all of our work, we deal in play. If we're not playing, we're not working. But the undercurrent of it is to help reduce those incredibly traumatic effects that prolonged hospitalization and even just your average medical event can have on a child. So that's our goal. That's what child life specialists are all about. Some things that we value, we work with the spectrum of what families and kids can look like. We work with teens, we work with infants, we have child life specialists in our NICU here at the hospital. We work with families of all sorts. We value play above all things in the way that it is a healing modality, that it allows children to learn and process what's going on in a stressful environment. We highly value our therapeutic relationships, our ability. I heard a couple of you when you were sharing your experience say they were my best friends, and that is like so childlike. Our ability to build rapport and strong, trusting relationships with children, families, and the professionals that we work with is how we're able to get things done. My job when I first walk into a room to meet a patient is to get them to trust me like this, so that I can help them engage and learn and cooperate with what's going to happen. So that's a really big tenet for us. We like to think of ourselves as the safe person. I am your safe person here. I am only here to help you feel comfortable, to help you understand what's happening. I do not touch. I do not do things you do not want to do. I am your advocate. We value communication in all its forms. We're working with individuals who are experiencing differences in their body, who are incredibly stressed, and their communication might not be the same. So we're always looking and advocating and elevating any communication that we see in an individual. That's a skill we have. We're always, we got a big stressful procedural room or ER room, whatever it's looking like. We have got eyes on that kid. I see my nurse pull out a flush and I see the kid's eyes just flare just a little bit. And I go, oh, okay, perfect. I'm seeing some communication that specific piece stressed you out. I'm going to make sure I address that really quickly. We have theoretical foundations of practice. We are part of a certifying body, the Association of Child Life Professionals. We're just as legit as all the rest of you, even if we deal mostly in bubbles and Play-Doh. But we hold tight to our ethical standards, the foundations of child life practice. Child life as a profession has been around since, it's on a t-shirt I have, I think like 1940s, 1950s. Emma Plank, our originator. So we hold tight to those things and do a lot of great work to keep ourselves up to date on child development theory, family systems, etc. Professional collaboration, child life. This is my favorite part of child life and why I gravitated to it more so than being a play therapist or being in schools to work with kids, is that we work with other professionals constantly. We are the intermediary between physician teams, anesthesiologists, nursing, bedside, the EKG tech. We help collaborate with all of those people and help kind of transition between what they're thinking and what the child is thinking. So that's kind of a knack that we have, is understanding the medical side well enough that we can help a child cooperate or participate or understand. And then finally, those professional standards of practice that we adhere to. And we also follow research, stay current on things to promote our profession and to continually prove why it is so important and so helpful and so valuable. So why child life? Why not just nursing? Why not social work? Child life serves a really important need. Kids can't heal and get better or stay healthy when they're constantly stressed. If I saw a couple of you nurses, we've got some backgrounds in nursing, you got a lot going on already. And a child needs a full undivided attention to really help reduce that stress. It can't just be a like one statement thing, right? We got to answer a lot of questions. We've got to have an opportunity to have a long play session. And child life can really fill that role. We can also really help things move along in the hospital. You can give every kid sedation. You can just knock them all out, get everything you need done, send them home, right? This is dangerous. It's not, it's expensive. It doesn't teach anyone anything. And child life can really help be that person to reduce the need for those kind of medicines or heavy pain medicines, by promoting learning skills. My next slide here is about what stresses kids out in the hospital. I bet you have no guesses as to what that is. Anybody want to come off mute and take a wide swinging guess as to what is the #1 most stressful thing in the hospital for children? Anybody want to take a crazy guess? Let's hear it.
Blood draws.
Yeah, nailed it. It's pokes, it's needles. They're the worst. Every kid will tell you every time it's pokes. You're going to hear that answer 5,000%, but there's a lot more secretly. Loss of control. We are constantly taking away body movements, ability to choose for yourself, privacy, unfamiliar environments, especially for our infants and toddlers. We're putting them in different routines, schedules, etc. Body changes. Sometimes literally your body changes what it looks like, feels like, moves like. Information overload. Talk about a stressor, right? Especially if I am able to understand what's going on, but also still am a 12-year-old. And all of a sudden we've got this new diagnosis or this big scary thing. I've got all these totally new language, right? You've been in the hospital, you've experienced something medical, you've heard a physician talking to you, and you are an adult human, and you're like, what were any of those words, right? Imagine being 12. That's information overload. Disrupted schedules, especially again for our infants, our toddlers, separation from parents or peers. You can't go to prom, you can't hang out with your friends, you got to be here. Parent caregiver stress levels. We get our information from our parent. Is this okay? Am I okay? Am I safe? And the parents that we see here are extremely stressed. So that passes off to the kids in our group. So a big stressor, a big factor. So why child life, right? Let's kind of reiterate that. 90% of children experience some sort of behavior change after a prolonged hospitalization. That's almost every kid that walks out of here is going to feel some sort of effect from having been hospitalized or having had a prolonged medical experience. That's really intense. We see a lot of regression, sleep disturbances, getting topsy-turvy, sleeping during the day, differences in naps, developmental delays, an infant hospitalized for a year, 6 months, incredibly at risk for missing some developmental milestones. We're not doing tummy time. We're not being able to reach, grab, see things. So that's where child life can come in, right? Stranger and separation anxiety. We do a lot of that here. Sometimes we have to take kids away from their parents to get medical care. People come into your room and something painful happens. So that's going to give you some stranger anxiety, increased acting out, withdrawal, hypervigilance. Again, that kind of, I've learned this lesson to be vigilant. And then just general fear of healthcare settings. If you talk to many adults that have, would tell you I hate the hospital. It almost always goes back to an experience they had in childhood of a healthcare encounter being really rotten. And all of these things that I listed are things that Child Life addresses in our day-to-day work. We work really hard to help reduce those negative effects as much as possible. So what are we doing? Let's go through kind of some of our job role. Child life specialists work across a healthcare system. So depending on where you work, your day is going to look really different. We have a child life specialist that runs our playroom. We have child life specialists on same-day surgery. We have them in the ER. We have them on our inpatient units where kids spend the night, in our intensive care unit, in the NICU. So it's gonna look really different. Everyone, though, is able to kind of take a look at who they might see for the day, except for us emergency department rats. We don't get to know what's happening, but you might take a look at what you have going on, assess based on their variables, their age, their coping style, their ability to communicate, family variables. Do they have family present? What kind of cultural differences might there be? And then we consider their healthcare variables as well. What's their diagnosis? Is this a new diagnosis? Have they had a lot of experiences? I've had 20 blood draws in the past. I've never had one. Is this a sudden thing? Is this getting a little bit scary because it is coming out of nowhere? So we consider all of those stressors and possible variables to address who we see, when, and for how long. Once we have assessed who we should see, we are able to provide oodles of services. We provide a lot of preparation. That's mostly what I did in the emergency department, and happens a lot in our like outpatient areas where procedures are happening, but child life specialists work other places too. We do that in age appropriate ways. You probably have seen the like dolls that you color on, and we can practice on those dolls. We put on anesthesia masks. We do blood draws on the dolls, really helping teach kids in an age appropriate way, utilizing play, real medical supplies. We can procedurally prep a kid in oodles of ways, and it looks really cool. It's one of my favorite parts of my job. We also, during that process, talk about coping skills, plans, like, do you want to sit on mom's lap? Do you want to watch a movie? Let's give you as many choices as possible and control in the situation. And then we implement that through procedural support. So a couple of you mentioned like helping with IV starts. So I do an IV prep with a kid. I'd help explain what was going to happen, engage in question asking, teaching back. And then during the procedure, I would help the child do what we talked about. Okay, remember your jobs were to take really big deep breaths. You said you wanted to count to 3. So I'm going to make sure the nurse counts to 3. We're going to have mom, so I'm helping make sure that they have that structure in place. And then we do a lot of distraction, sometimes conversational distractions, sometimes watching a show, singing a song, looking at a toy, light spinners, bubbles, based on what we talked about in that prep. Behavioral pain management. This is something we get consulted for a lot, helping kids manage chronic pain, new pain through learning new coping techniques, engaging in play or distraction. We do a ton of healthcare play as well, open-ended play, medical play, sometimes teaching play, giving kids an opportunity to manipulate things that they're seeing or experiencing in a way that they get to control and run the show. We also just provide play, just a regular old play. Our child life specialist that runs the playroom is in a constant state of hustle. She is making sure that if you want Paw Patrol toys, we can play. We, can get you access to balls, cars, everything. We have slime. Oh, I wish I knew the statistic. It always leaves my brain, but we have the like numbers of how many gallons of slime primary children's goes through a year. I think it's like 300 or 400. It's something like that. 300 to 400 gallons of slime come through this hospital and out this hospital. And all of that is so critical. It's all very, very fun. But as we talked about, those whys behind child life, gives kids control. It helps them do something more a part of their routine, helps them learn and engage in the experience around them. It's wonderful. And then finally, grief support. We do a lot of bereavement work here, along with our social work teams and our bereavement coordinator. We're often providing mementos for families during a death, providing sibling support, helping talk about what's happening, and then talking with parents about how to talk to children, if that makes sense. So if you've got a child dying and siblings that are under 18, talking about ways that children understand death and how to be supportive. So when should you call us? When, would it be appropriate to tell a family to call child life or to recommend they ask for child life? Those would probably be the ways that your team would be engaging. If you feel like they need preparation for something that's coming up, having them give us a call, especially ahead of time. Our team teaches pre-op classes. That's one of the few scheduled things. So it's a great one to teach about ahead of time. We have videos about having surgery that use age-appropriate language. You can come into the hospital and take a tour with a child life specialist and see what's going on. If you feel like they need support during the procedure, recommending that they, ask for child life. If they feel you're needing some resources or education about typical child development, specifically related to something medical, we have a lot of those resources. Sibling sessions. not just for bereavements. Our ICU child life specialist, for example, does a lot of sibling work, as well as our NICU child life specialist, helping kids understand, helping promote a connection between sibling and the hospitalized patient, to help them feel connected, maintain a relationship, help them understand what's happening with their sibling, etc. If the patient is having a difficult time taking medicine, generally just cooperating with treatments. If it's something that has to keep going on, using an inhaler, taking a medication, etc. We do pill teaching education, pill swallowing, and then just general recommendations about cooperation. If you have support needs for someone related to death and bereavement, our team does consult for children of adult patients occasionally, especially at our facilities that are adult facilities but have child life specialists, which I can list those for you before we're done. So either a child death or death of an adult, we can oftentimes, we wish there were more of us out there in the world, but we can consult for those situations. Needs help coping or understanding a really new diagnosis. Non-medical help just with coping with pain management or coping with the new stressor. We're very good about like knowing where our boundary lies and where it's time to go see therapist or seek outpatient support, but we can do some of that support as well, especially at bedside. Just general, like unusually fearful or distressed. We use this list for our nurses and bedside staff members as well. So we're kind of just saying, like, if you're like, I don't know what's going on here, we have that skill of being able to walk in the room, kind of assess, see if we can suss out what exactly is making that person so fearful or distressed. And then finally, just opportunities for age-appropriate play. We don't want any kid sitting in here that feels well enough to play, not able to access play. If I can't use my left arm right now, we can figure out a way to help you play. If I am, awake and alert, but can't really move my body, we can play for the patient. We can make all sorts of play opportunities happen. So calling us if you're worried about access to that. Next, I'm going to go into the adaptive care plan, but I'd like to take a pause and see what kind of questions or clarifications you have about child life services in general. When we're all done, I will share like what hospitals we're at, just to clarify, and our contact information. But just generally about child life, what kind of questions do you all have, or what kinds of clarifications can I make? Did I explain it all perfectly? It's terrible news.
Emmy, I want to comment. My name's Natalie Allen. I'm a nurse practitioner and I work for Eric's team integrated services program. But I had a daughter, my granddaughter, who was at Primary Children's she was originally misdiagnosed. It was a missed appendicitis, and she got incredibly ill. She was so sick and so miserable. And Child Life did great things for her, but I want to comment on how they were able to help my daughter, her mom. So my daughter battles severe anxiety, and I, as the grandmother, wasn't sure who needed more help, my granddaughter or my daughter. And I know that you're called a child life specialist, but what you were able to bring to that mama was incredible at that time. Now, my granddaughter also remembers, and when she talks back to the hospital about the hospital, and whenever there's a blood draw, she wants to go back up there because she thinks it's magic, that's where you go. But anyway, I just want to comment on how you were even able to completely support a mama that was not in a good place. Hence, you helped the grandma who didn't know what to do with her either. So thank you for what you do.
Natalie, I'm so glad to hear that. Thanks for sharing that experience. It really, you're so right. We deal a lot in play, and that's how a lot of people recognize us. But like my degree is in child and family studies. We're treating the whole family, right? That's family-centered care at its finest. The best thing we can do to support that child is to help lift her mom up, help her feel more comfortable about what's going on, talk about what's normal, talk about what we can do today. So I really appreciate you sharing that perspective. Any other questions or experiences about child life specifically. Okay, well, let's keep going. Adaptive care, that's what I do. That's my job. The adaptive care program is brand new, brand spanking new. We started in February. We were doing a pilot program about a year or so before that, but we are officially just since February. So we're a little green. I'm going to share this amazing resource with you, and I hope that you keep a little nugget in the back of your brain of saying they're really, really new and they're working on their resource and timing management, so that you'll be kind to us and not send us every kid you ever met in your whole life. But the adaptive care program came out of parent complaints, honestly. Parents of children with developmental disabilities letting our administrative team know under no uncertain terms that we were not meeting the mark for the adaptations needed for their children to access healthcare. And frankly, I think that's wonderful. I think letting us know where we need to get better structures in place to support families is exactly what hospitals need sometimes. So kind of wonderful that it came out of that. Because of that feedback, the hospital decided we could start an adaptive care program. These are becoming more popular across in children's hospitals across the country. So this is not like a brand new framework. It's just something we are adopting. Our general goal is to reduce stressors. It really aligns a lot with child life, which is why we are kind of heading up the initiative, to reduce those stressors and achieve positive, more productive healthcare encounters for kids with developmental disabilities. That is our goal. We do that by identifying and communicating individual needs. So this is a program for kids with developmental disabilities to help improve their hospital experiences, more or less. It is under Child Life and secretly run by Child Life specialists, but we are considering this a hospital-wide program. You do not have to have a Child Life specialist at your bedside all the time to be part of this program. It is something that is built for our nurses to use, our techs to use, our physicians to use. We hope it makes everything easier for everyone. The criteria for participating in the adaptive care program is that you have to be older than 3. Reason here being, we're going to be creating plans for these individuals, and creating a plan for an 18-month-old, we're going to have to update it every 2 to 3 months. So it's just not practical. And we also don't know as much about preferences, things like that at that age, right? We're still just learning some basic skills. So 3 and older, there is no age cutoff technically. You can be a 60-year-old individual with a developmental disability. We could technically still write you an adaptive care plan. Second criteria, you have to have all 3. You do need to have a developmental disability. We're most commonly seeing autism, Fragile X, trisomy 21, general, just global developmental delay, intellectual disability. All of these things are what we're looking for. We're looking for kids who the way they understand, learn, and participate in the world is different than their neurotypical peers. And then our third criteria, a little bit trickier to classify. Our team is working on how we do that. We're getting a little bit better at it, but it's always a bit of a discussion. Sometimes someone sends us a referral for a child, and we, through talking with a family or asking questions, we decide they don't qualify for a program. So it can always be a little bit of back and forth if we aren't sure, but we do want to see a difficult time coping and cooperating beyond what's age appropriate. We want this program to be a power tool for kids who really need a lot of adaptations. We want our nurses, when they see an adaptive care plan pop up for a kid, to go, oh, it's time for me to pay attention. I need to do something different here than I might for a typically developing 7-year-old. So we're not looking for every 5-year-old with autism that cries when they get an IV, because guess what? IVs are pretty stressful, and it's super age appropriate to cry when you get an IV. We're looking more for kids who have a difficult time entering the hospital space, transitioning to a new room, having safe behaviors, who maybe are non-speaking, so aren't able to communicate with our team in a way that we would expect. For individuals who can't tolerate touch, vitals, things like that. That's kind of what we're looking for. Those are some of our easy markers that a kid would qualify. And then how are we implementing this program? We're writing adaptive care plans, and I'll show you a little bit about what they look like and what's involved in them. But they are written via interview with a parent or family and a child life specialist. We also will be training occupational therapists in our outpatient settings to write adaptive care plans as well. Those plans can also be supplemented by observation. If we have a really good appointment with an individual and we learn a lot, or a rough one, we can supplement that with what we see. So that's our biggest deliverable, is those adaptive care plans. That's mostly what my team is doing right now. We're also providing tons of staff education hospital-wide, helping our units understand how to use this program, when possible, teaching them about better skills in working with individuals with disabilities, really trying to the slow start of some cultural change in better skills in being affirming to our neurodiverse populations and individuals with disabilities. And then we're acquiring and accruing tons of new physical resources so that we're better ready to support individuals with sensory differences. This includes just supplies floating through the hospital, better access to noise canceling headphones, vibration shoe items, weighted items, and Primary Children's main campus very, very recently got a sensory room, which is really, really exciting. It is beautiful. It's on the 3rd floor, the main inpatient floor. We're very, very new also. So working a little bit on how we schedule and get kids in here, but will in the future be prioritizing kids who really need a regulatory sensory experience in order to be regulated, to participate, and to be accessing the care that they need. So we'll kind of work on appointments and things like that, but it's an awesome room. We can totally do sensory control. We can close blinds. We have bubble tubes. It's really great. And then finally, we have additional child life support for adaptive care. So that's me. And then my coworker at the Lehigh campus. We're both writing adaptive care plans, working with families, etc. Okay, so where are we at? As I mentioned, we have done a pilot stage. We did a lot of listening. That's where I was bugging Colleen a billion times, coming to the Utah Parent Center, connecting, really trying to inform our program based on what families and individuals really want and need. And we are now rolling it out. This is a little minutia for all of you, but technically we're rolled out to the Children's Procedure Center, same-day surgery, the neurotrauma unit, and the rapid treatment unit. Our behavioral health team is also utilized. So we're kind of staging the usage of our program. We currently have 114 kids with adaptive care plans out there in the Intermountain system, which is really exciting. We're super proud of that. And we'll just keep trucking along, getting more referrals and rolling out to more spaces. So for all of you, that means that if you're looking for a website for us or calling a unit, I don't know, to help coordinate something, you might not have people knowing exactly what we are all the time, but you'll notice that getting better as the year goes on and more people get education and information about that. So that's why I kind of clarify where we're at. And then this is kind of what our staff is experiencing. So when they open up an individual's chart note, they get alerted to the fact that they have an adaptive care plan. They're able to click on the text really easily and open up that plan. So I'll show you an example of what they are looking like right now. We always give a disclaimer. We have 5 different sections. Every interactions for everybody. Gives you things to get off on the right foot with. Can this kid wait in the waiting room? These kind of things. Behavioral information so that our staff can interpret behaviors correctly and stop and make new plans before we see escalated behavior, and also know what families want, what is supportive to them. We hear all sorts of things, right? Leave us alone, please, or please can you go get me things, So clarifying that, we have a lot of procedure and medical specific information, what adaptations are most helpful for vitals, what is a good anesthesia plan, what kind of things should we try and avoid where possible, and what kind of things can we give. Coping and communication gives us exactly that. What kind of supports are really helpful so that we can see positive coping. And then some sensory information so that we can help kids avoid and provide things where possible. Here's another example just to show you how our structure is always staying the same. Our interview process with families is always about the same, but we're able to individualize that. We really like this document. We can edit it. We can add in, like if a kid has a port, we can add in a port access section. We can do all sorts of things based on how much we know about a kid and where they're coming from. And so you all know when a kid gets referred to our team, we review to make sure that they qualify. So not promising that, you'll definitely get an adaptive care plan, whatever, but that you can have a conversation about it. We call and email families one time each, give them our contact information, all that good stuff. And then once we engage in creating the plan, it generally takes between 20 and 40 minutes to get through the interview, ask lots of questions, and get really quality information for our plans. That's it. That's all I've got. But I'm very, very open to questions and would love to share lots of our contact information, all that good stuff, but I can put a lot of that in the chat. I did say I would tell you where Child Life is. I'm going to stop sharing. Child Life Specialist in the Intermountain System. I cannot speak for the University of Utah. We are at Primary Children's, obviously, Eccles Outpatient Building. We are at the Lehigh campus in many numbers. We are at St. George. We are at McCady. We are at Utah Valley, American Fork, a little bit still at Riverton. A lot changed with the Lehigh campus opening. A lot of pediatric units closed or they stopped doing surgeries there. So some of that area is a little bit in flux. And then we will soon have a child life specialist up at the Park City Hospital. We have an open position there that we're waiting to fill. That's the places that we are at. Okay, I'm going to start working on putting some contact info in the chat, but I'm ready for questions now. I'll stop talking.
I mean, let me just ask you a question. This is, very much hospital based and, do you see this at any point kind of like branching out into clinics or provider offices or anything else, like that there's it just seems like it's a really great way to kind of, mitigate fears and behaviors that this can be terrifying, even just going to the doctor's office because well child checks, you're getting immunizations and you're doing all sorts of not fun things. My middle son, who's now 28, was going to peds endocrinology clinics, and we were dealing with insulin injections and putting in sites and continuous glucose monitor stuff. And, after a while, the kid gets used to being a pin cushion. But when up until you get to that point, it takes a minute. So I'm just kind of wondering like where the thoughts are of like this type of, really important, skilled type of building relationship with kids. If you see that kind of, transcending beyond, like hospital or like outpatient type set or like those hospital type settings.
Yeah, no, that's a great question. So many child life specialists do consult to outpatient clinics that are on our site. So like the Eccles Outpatient Building where we have cardiology, neurology. We have a child life specialist specifically for our dialysis clinic. That's an outpatient area. If I could put a child life specialist in almost every like community pediatrics group, urgent care and dentist office, I would. I will say our profession is a little bit in flux right now. Here's the tea is that our certifying body has not done a great job of like creating a structure to make more child life specialists. So we're a little bit thin anyways, even for medical settings. But there are certainly areas where Child Life is working on a more community basis. There's none in Utah, but there are community or private practice child life specialists that work across the country and go into families' homes even. That again is not something that's happening here. It's a little bit spotty, but yeah, so there's like kind of a more broad answer to your question, which is that, I mean, I think that would be wonderful. I don't see it happening anytime soon, getting child life specialists more on like, you know, like you said, like a pediatrician's office outside of the bounds of clinic buildings, you know. But we do have some of that support here in our outpatient clinics and the Lehigh outpatient clinics as well. Did that answer your question kind of okay? Yeah.
Yes, it did. And it was pretty much the answer I expected. It just seems like it's a really, you know, great idea. And I think would really help, you know, just with a lot of issues that you see just, I mean, again, in just
Absolutely.
Pediatric offices. I mean, I know when you go up to like, you know, primary children's, a huge clinic like that, you have access to all sorts of, you know, like ancillary services, social work, and, you know, to all sorts of different things. But, you know, that ability to have access to something like this just seems like could
I will
really be
say,
beneficial.
thinking of one edit to my answer, which is that adaptive care plans, which again are only serving some of our population, but they will alert to any pediatric staff. So a pediatrician's office in Santaquin, they will get an alert at least. They might not have a child life specialist to implement a bunch of the extra stuff, but as you kind of saw in our plans, we write them to be read, I say, by our 20-year-old tech taking your vitals. So they're helpful even if you don't quite know what's going on. So that service is available pretty much across Intermountain.
Perfect.
I mean, I have another question I'm not sure you'll know the answer to, because a lot of the clinics that are run out of Eccles are not necessarily Intermountain clinics, but University of Utah clinics. Do you know, are people able to access Child Life in all the clinics there?
Great question. If they ask specifically, yes. We bill our time to the U. Like if I go spend an hour and a half with the dermatology clinic, I just have to write it down and we bill them for our time. But yes, they have to call us specifically. We will not seek out that child. But if you tell a family, you should ask them to call Child Life when you're there. Then if that team calls us, we will come. Yeah, great question.
Maybe this is a secondary question too, to that adaptive care program. Is it only seen in like the Cerner EHR? It wouldn't necessarily show up in their chart if it was in Epic.
That is correct, unfortunately. A lot of the U clinics that operate out of primaries have access to Cerner. Do they open it up? Not really. We do, when we speak with families, encourage them to continue self-advocacy. We have an adaptive care plan. It's in our primary chart. And I would hope a kind U physician would take some time to open up Cerner. But yeah, it is not currently flagging. I don't know if that will change when Intermountain switches to Epic. I don't know if all of you know that, but Intermountain is going Epic. Oh, yeah, I know. This is like really big. So I don't know if when that happens, if there will be better information sharing. I somehow doubt it, but that could potentially change in the future.
That's great.
Other questions, comments, concerns? How do you guys see yourself? Oh, wait a minute, someone came off mute.
Yeah, would you mind putting your email also in there, or do we just do email adaptive care at email.org?
Yeah, I'll put my
Thanks.
personal email in there. Adaptivecareiml.org is better for adaptive care needs, because I know this is shocking, but sometimes I go on PTO, or I don't want to, I am not the program. The program is not me. So it's better for those kind of needs, but you can email me too, just for fun. Tell me your favorite color, what you like. I will put that in there.
Thank you.
Hey, I had another question. I'm not sure you'll know the answer to as well, but I know you're most familiar with the Intermountain system and where Child Life is. Do you have any insight on where Child Life can be found outside of Intermountain?
Yeah, a little bit of this could be wrong, but I'm pretty sure there's Child Life at Timpanogos, just a couple, like on their peds unit. I'm pretty sure there's one Child Life specialist at Davis. She used to work here. And then the U has a Child Life specialist on their burn unit. I think they have another one somewhere else. They have like maybe two Child Life specialists. Maybe. One is definitely burn unit, because she also left us and went there. I think that's it. Might be. Great question.
I was going to also ask you, Amy, like on some of your frequent flyers, some of your kids that are up there all the time, do they consistently have the same child life, kind of specialist? So,
Often.
okay.
Yeah, often, like our dialysis kiddos, you're getting dialysis until you get a new kidney. And they have a consistent child life specialist. Ditto our heart kids. We have kids that live here for years, waiting for a heart. So they have a consistent child life specialist. Unfortunately, I think a big gap for our team is that we have not had consistent child life coverage in our outpatient clinics. So kids with spina bifida, kids with CP, diabetes do not have a consistent child life specialist. So there's some gaps in that with chronic populations, just due to how we've been able to get staffing. But some of our populations that is consistent. Our oncology patients also see the same person.
Okay. Yeah, I was just looking like kind of from that consistency, knowing, somebody familiar face every time kind of a thing. Okay.
Are there different languages that this service is offered in?
We have a single Spanish speaking child life specialist. She works on 3 Northwest, which is our like post surgical unit. Golly, if we could clone her, I would really like that. But as I mentioned, our profession is really thin right now. We just have had some issues there. So let alone Spanish speaking child life specialists, we just need child life specialists as well. So hopefully that will increase in the future as we see our team reflecting our community a little bit better. But we use translation services just like the rest of the medical teams. I have honestly done some really wonderful work with some of our in-person translators. It's really fun watching them go like, and they go, so we can make it work. Usually we get a lot of in-person interpretation, which is helpful for child life, because it's we're talking to kids. We got to have engagement.
Thank you.
Thank you so much, Emmy. This has been a great presentation. It's been so wonderful to hear about the new adaptive care program, and I'm sure you'll be hearing from some people on this call, especially of knowing people that are headed to the hospital that might need some extra support in that area as well. So I
Love it.
really appreciate it.
Heck yeah. Thank you for having me. Spread the good news. Child Life exists. If you ask for it, we generally come. And for adaptive care, our request would be like referrals right now would be kids that are coming for something actively. We don't quite have the staffing capacity to do all the routine, no appointment coming up, but they would benefit from it. We're kind of trying to titrate our amount of referrals. But if you got a kid that you think would qualify for those criteria coming up for something in the next month or so, give us a shout. We can absolutely work with those kind of referrals. Thanks for having me. I appreciate talking to all of you this morning. Thank you.
Great. So just to wrap up our meeting here, before anybody signs off, we're going to institute a new just evaluation at the end of each meeting. We want to make sure that we're capturing people's thoughts on the learning session and giving everybody an opportunity to give feedback on every single meeting too. It's just 3 questions. So I'm gonna flip to the next slide, but launch that poll, and then just as you're able to do it, go ahead and fill that out. So let me get this launched while I'm just giving some wrap-up information about our next meeting. So our next meeting will be June 19th. And we are really excited. We're going to have a panel of people to talk about autism, and it's people that are going to represent services in autism across the lifespan. So we're very excited to have a panel of people come for that meeting. We'll probably be doing a little bit of question collecting through the listserv before that meeting happens as well. So at the moment, we have diagnostic services represented, some education services, with people with advocacy experience. So we're really excited about it. It should be a really great meeting. So plan on that. And then again, as always, you can stay connected in between meetings by using the listserv email. You can mail questions or resources to that directly. It will distribute to the entire listserv. Or post things on our Facebook group as well. So just go ahead and take a moment to fill out that poll if you would before you sign off, and we'll plan to see you all in June. Thanks, everyone.
Thanks, Athena.
Hey, Eric, is the
Yes.
poll, are you able to see the poll?
Yes.
Just curious. You see the results of it?
I didn't see anything because I took the poll. So I could answer those questions up front,
So
but I
you
didn't
just see the
results.
questions. Okay.
I just see the questions.
I was just curious what the view looks like for.
Yeah, it was just like good old poll that like we used to see, and you take the poll and that's it. So
Perfect.
Yeah.
Is that what
you,
you
you
were
always
kind of
you always
hoping
wonder
for?
if you always wonder if the technicality or the technology is going to work. So it looks like it did just fine.
That's great. Great.
I
Okay.
appreciate you doing that. Thank you.
And then do you want me just to send those over to you in like an Excel file after each meeting?
Yeah, after each meeting, I'll compile those and then we'll just look at those just overall. And then that just helps me with Title V things as well. So yeah, just send them over every meeting and we'll hang on to it. I appreciate you doing it. Thank you.
Great. Thanks.
Okay, sounds good. Thanks, Athena.
Mm-hmm.